Okay, good afternoon, everyone. Thanks for joining today. My name is Andrew Scotes. I'm a councillor for Beeston Holbeck, and I am the chair of the Adults Health and Active Lifestyle Scrutiny Board. Today, we're going to have, I think, a really interesting meeting. We're going to talk about the mental health strategy and the Leeds Be Healthy plan. I'm going to start with some introductions, so we'll go around the table if that's okay. Just before we do that, just want to inform everyone this meeting is a public meeting. It's being broadcast on YouTube and is available for watching later on as well if you're interested. So I've already introduced myself. I'm Andrew Scopes, Councillor for Beeston Holbeck, chair of this board. We'll go to my left. Thank you.
Good afternoon, Toby Russell, clerk to the board.
Good afternoon, I'm John Beale. I chair Health Watch Leeds and I'm a co-opted member of this board.
Councillor Mahiri France-Mear, Councillor for Moortown and Meanwood.
Good afternoon, Councillor Taylor, and I represent Chapel Allerton Ward.
Good afternoon, Councillor Gibson, and I represent Crossgates and Winmore Ward.
Mohammed Iqbal, Councillor for Hunslet and Riverside Ward.
Good afternoon, everybody. Councillor Kevin Ritchie, Bramley and Stanley Ward.
Luke Farley, Labour Councillor for Bermondsey and Richmond Hill.
Councillor Conrad Hartbrook, Councillor for Rothwell.
Afternoon, everyone. Councillor Paul Olson, Guiseley and Rawdon Ward, and I'm subbing for Councillor Sam Firth today.
Good afternoon, I'm Councillor Caroline Anderson. I represent Adel and Wharfdale Ward.
Good afternoon, I'm Angela Brogden. I'm the Principal Scrutiny Advisor to this board.
Thank you very much. And those around the table, start with Councillor Arif, please.
Good afternoon, I'm Councillor Salma Arif. I'm the Exec Member for Adult Social Care, Public Health and Active Lifestyles.
Hello everyone, Victoria Eaton, Director of Public Health, Leeds City Council.
Can you just use your microphone, please? Thank you.
Sorry, rookie mistake. I'm Alison Kenyon. I'm the Deputy Director of Service Development with Leeds and York Partnership Trust.
Hello, I'm Liz Highmarsh. I'm the Programme Manager for Community Mental Health Transformation. Nice to meet you all.
Hi everybody, I'm Karen Walker, Chief Officer and Consultant in Public Health.
Tony Cook, Chief Officer, Health Partnerships and Chair of the Mental Health Strategy Group.
Hi everybody, I'm Caroline Barrier. I'm the Interim Director for Adults and Health.
Super, thanks everyone for joining us. Okay, I'm going to just go through the first few formal items and ask Toby to run through them for me. Thank you.
Thank you, Chair. Under agenda item number 1, there are no appeals against the refusal of inspection of documents. Under agenda item number 2, there are no items which would require the exclusion of the press or the public. Under item number 3, a late item of business, which is item number 11, has been added to the meeting agenda with agreement from the Chair. This item relates to Leeds Tier 3 Specialist Weight Management Service. Under agenda item number 4, can I ask members to declare any interest they may have? Thank you. Under agenda item number 5, apologies have been received from Councillor Firth with Councillor Alderson acting as a substitute, and we've also received apologies from Councillor Kidger, and then we've also received apologies from Councillor Fiona Venner, who is the Executive Member for Children's Social Care and Health Partnerships. Thank you, Chair.
Thank you very much. Okay, moving on to the minutes. I'll start with any matters of accuracy. Anyone want to raise any matters of accuracy? Okay, good. Are we happy to move them? I can see nods around the room. Super, thank you. Okay, on to matters arising. I'll start with comments from you, Angela, please.
Thank you, Chair. So primarily in relation to minute number 10, which refers to the sources of work for the Scrutiny Board discussion. Firstly, just to confirm, the Director of Public Health is progressing the Board's request to raise the issue of cannabis use, particularly amongst young people, with the Drug and Alcohol Board in order to provide a briefing paper back to Board members, and that will help determine whether this warrants any further work from the Scrutiny Board. And I can also confirm that the Children and Family Scrutiny Board had used its meeting on the 5th of July to discuss a briefing paper from Public Health on the issue of vaping again, primarily amongst children and young people. And also to note that as chair of this board, Councillor Scopes was also present at that meeting. And in conclusion, the Children and Family Scrutiny Board have agreed to explore this further via a working group approach that will be arranged after the summer, and that's to include representation from this board as well. So this is currently being progressed, and members will receive further information on the meeting arrangements in due course. Thank you, Chair.
Thanks, Angela. Just want to comment also on that board meeting. I felt like it's really helpful debate about vaping. Councillor Lay spoke really well about the challenges, but also the ability that vaping does have to help people quit smoking. And so we've got to recognise that in any strategy. What Councillor Cohen agreed to do in terms of how we look at this was quite nicely was the three areas that I'd suggested. So what we can do as a council, what we can help convince our partners to do. So whether that's the police or trading standards or other partners in the city, and then also to look at what we need in terms of national legislative changes. And then we'll lobby as a cross-party scrutiny committee to do that, or his board will do that. So hopefully that'll be really positive. Are there any other matters arising that people want to raise at this meeting? Can't see anyone indicating, so we'll move on. Okay, so our first substantive item today is item number 7, which is the Leeds Mental Health Strategy. And I'm going to ask Councillor Arif to introduce it in the first instance. You can assume, everyone who's speaking, assume we've read the papers already, but if there's anything specific you want to draw out, please do. Thank you.
Thank you, Chair. So whilst mental health falls within my public health remit, I'm introducing this item on behalf of Councillor Venner in Councillor Venner's role on health partnership, as she has unfortunately another meeting today. We are partway through our mental health strategy 2020-25, which is a key part of the wider health and wellbeing strategy and our improvement plan for mental health. The vision is for Leeds to be a mentally healthy city for everyone and is owned by all partners and across sectors and has 3 passions. These are to reduce mental health inequalities, improve mental health of children and young people, improve flexibility, integration and compassionate response of services. Mental health needs to have been increasing over recent years, and particularly since the pandemic, for children and young people with long wait for some services. Work by Public Health shows anxiety and depression in school age and 18 to 25-year-olds is an increasing challenge, as are issues around neurodiversity such as autism and ADHD and gender identity. In relation to services, the mental health strategy acts as our roadmap for improvement. The 8 priorities are a better offer around health promotion and prevention, tackling overrepresentation of Black and Asian people in acute services, improving employment and educational outcomes for people with mental health problems, improving transition between children and young peoples and adult services, and a better offer for 16 to 25-year-olds, being a trauma-informed practice and think family, improve access to crisis and acute services, and to ensure older people have a good and supportive service offer, and improve the physical health of people with serious mental health illness. We'll hear from officers that there has been progress, but the challenges do remain, Chair, and in some instances are worsening with need, increasing across different demographics and waiting times being a challenge for many areas. Thank you.
Thanks, Chair, and thanks, Councillor Arif. And one thing it's worth pointing out, so I'm not going to talk particular for a length of time, that we had a session in March where we had a good run through the strategy. And some of the key things that were brought out were the importance of the community mental health transformation programme. So we've got Liz present with us, who can talk with some authority about all the great things that are happening under that programme. And then likewise, the importance of moving really strongly on public mental health promotion and prevention. So Karen's here to talk about that. And then more generally on some of the outcomes that the services are delivering, some of the challenges, and Alison can probably speak with authority about sort of the way we've managed the system over a number of years and some of the partnerships we've put in place. So Councillor Arif mentioned some of the challenges. I'm just going to highlight, there's a lot of things obviously in the paper, but I'm just going to highlight a couple of the things that we know are proving relatively difficult at the moment and that we're trying to action. So in terms of crisis services, we know a third of people that are accessing crisis services haven't been previously known to those services. And so obviously that indicates that the reach of our early intervention and prevention services isn't as ideal as we'd want. And that is particularly a challenge for Black and minority communities. So one of the things that we've put in place is a piece of work called the Synergy Programme, which seeks to improve outcomes in that area. Likewise, physical health, some recent data showing that lots of people with mental health problems have high levels of smoking, and there's premature mortality, i.e. early death, for a lot of people with particularly the most serious mental health challenges. Unquestionably, that's something we need to improve over the years. And then finally, as you might expect, some of the challenges of modern life that we see, not just in people with mental health problems, but across the board at the moment, housing challenges, employment challenges are undoubtedly influencing things like anxiety and depression. So one of the things that we know we need to further develop is employment support for people at all levels with mental health issues. So I'm just going to hand over briefly to Liz, who's going to give us a quick run through the community mental health transformation work.
Thank you. As the chair said, I'll assume the paper's read, but I thought it might be helpful just to pick out a few themes and some of the key discussion points, if that's okay. Thank you very much for inviting us to come and talk more about the work as well. We're really happy to share the work and take any questions. The paper sets out a bit of the why we're doing this, and lots of that will be well familiar to you all in your communities as well. And it also sets out the key areas of work, the work we've done to date and some of the progress and our next steps and some of the key challenges, which will be challenges that are common across the mental health strategy. Wanted to be clear on the scope of the work. So the scope is for adults and older people with what we're calling complex and ongoing mental health needs. In policy terms, that's often referred to as severe mental illness or serious mental illness. So it's more about the moderate to severe level of need and people with ongoing and complex needs, but really paying attention to all the things in people's lives that can affect their mental well-being and onward recovery. So access to good housing, employment support, social connections and things like that. Children are not in scope of this work, but really importantly, we need to pay attention to transitions, which we know is an ongoing area of concern. And also all the data around the growing need in children and young people. We need to be thinking ahead to what does that mean in terms of the demand that will be coming down the line into adult services. In terms of why we're doing this work, we've got lots of good provision in Leeds, particularly in the third sector. We've got a really rich and diverse third sector. But we know that lots of the services we have aren't very well joined up in Leeds. We have lots of different services with different criteria. And what that can mean for people is getting referred between services and that feeling of being bounced around the system, for want of a better phrase, which is a bad experience for people and also frustrating for the people that work in the system. And we also know we've got long waits to particular services and psychological therapies, and sometimes limited support for people once they're discharged from a community health team. So what we're trying to do is make better use of all the good stuff we've got and join it up together so that it's an integrated offer, paying attention to people's psychological needs, physical health needs and social needs as well. And how we've been doing that is developing the concept of what we're calling an integrated community mental health hub. And what that will be is a multi-agency, multidisciplinary team working with and around a local care partnership to best meet the needs of people with complex and ongoing mental health needs. And the paper talks a bit more about what they will look like. We want to start fairly small with those and test them in 3 local care partnerships so we can get some learning before we look to scale that up further in 2024. A lot of this will be about culture change as well. So there are some improvements we can make in terms of how people work together, but the culture change will be really important. So we've tried to pay a lot of attention to that in how we've done the work. So it's been a lot of partnership working across all sectors, lots of engaging with communities and working with people with lived experience throughout all the work. We've been working closely with Healthwatch and Leeds involving people to lead on that involvement and engagement work. And in terms of next steps, we're very busy at the moment in terms of mobilising to pilot those first 3 hubs from the autumn, and then we'll be looking to scale up further next year. The other point to make is this programme comes with significant investment. So we've been using a lot of that investment to get ready for this new way of working. So we've recruited a lot of additional roles across the NHS and the third sector, and some additional specialist mental health social worker roles. And we've also invested money for community grant funding, and that's about getting money to real grassroots organisations to try out some different types of community support. So that was really the kind of summary I wanted to give, and happy to take any questions. Thank you.
Do you want to come in again, Tony?
Yeah, I mean, it depends how you want to do this. Obviously, Karen can maybe give a couple of minutes also on some of the public mental health and early intervention, which is obviously, you know, really closely connected to how we manage other parts of the system.
Yeah, I'm here this afternoon, partly because my team, the public mental health team, provides us strategic leadership for Priority 1. But also I also chair the Mental Health Partnership Board, co-chair it with Hannah Davies from Healthwatch. So if there's any questions around the partnership board, I can certainly answer them, because Hannah wasn't able to make it this afternoon. You'll see from the papers that we're very much focused on Priority 1, which is about targeting mental health promotion and prevention. So it's very much upstream work that we do across our team. So it's you know, thinking about increasing protective factors for good mental health and trying to reduce those many risk factors that we're aware of for poor mental health. So we have a number of approaches to do that. We use things like 5 ways to wellbeing. We do fund training across the city for mental health and suicide prevention work. And because we also lead on workstream 1, which is about focusing on supporting populations impacted by the pandemic to stay mentally healthy, we're funding some work around, I suppose the best way to describe it is helping to get resilience in those people who are helping others. So volunteers, whether that be in food banks or cafes or other areas where people actually trust those people that work with them on a long-term basis. So training up those people to be able to better look after their own mental health, but then to be able to help others as a consequence of that. So that a lot of our work is around that. You've probably had a mindful employer. That's some of the work that we do. But we also work across the board around reducing stigma and discrimination in terms of poor mental health and everything that goes with that. So we're quite involved with Priority 2 as well, around reducing the overrepresentation of people from some ethnic minority communities. But the other area of our work is, which some of you will be aware of, is reducing suicide and self-harm. So we have a whole programme around that. But our work is very much focused on trying to keep people healthy before they get into have to end up into the system. So it's about targeting those approaches. We were very pleased to launch last Friday our new programme around keeping people mentally well across the city. And that's called Being You Leeds. And some people in the room have got their badges to promote that. And we're doing this slightly, well, quite differently to how we did it previously. We've got a provider collaborative. So there's 7 voluntary sector organisations that came together to bid for this contract. I can give you details if you want to know which organisations are involved. You'll have heard of most of them. But it's all third sector organisations working across the city to promote training, to promote group work and activities, and also to tackle stigma and discrimination around mental health. So I can give you further details at any point you want around that, but we are very much focused on the upstream work around keeping people mentally well and mentally healthy and being able to talk about their mental health across the city. So I'll leave it there. Liz, can you say that?
Councillor.
Yeah, just thank you for that, Chair. Just to add really in relation to Beyond You Leeds, when we were having the conversations, it was really important that we felt that we needed to go into the community and work with providers that were from the community, that understood the needs of the community, and recognising that every community is different. So I just really wanted to echo what Karen has said, and the need for us to ensure that that support is available at a grassroots level. Chair, thank you.
Super, thank you very much. I'd just also like to just say thanks to Tony, because you've added quite a lot of extra data since Chair's brief, and I appreciate that. That's helpful. If you want to ask a question, please indicate in the usual way. I'm going to just start by asking a question to start us off. It's just around neurodiverse assessments for children. So my understanding is we are not where we should be, and really keen to know how we're going to catch up. Thank you.
Thank you, Chair. The world of neurodiversity is really quite challenging at the moment. In the last few years, we have seen a significant increase in both children and adults referrals to neurodiverse services for assessment. And the increase, and I'm going to say it's about doubled in the last few years, and the increase has meant that the capacity of the services that we provide across Leeds and beyond does not have the capacity to cope with the increase in referrals. And there's been some significant challenges around workforce across mental health service providers, and which has included the neurodiversity teams as well. So we have had gaps in workforce provision there as well. Another part of my day job is I am the Senior Responsible Officer for the West Yorkshire Programme on Neurodiversity. And we've been doing a piece of work that looks at the amount of money that the system, the NHS system, is spending on assessments, because people have the right to choose to go to a private provider if they have to wait longer than the recommended waiting time. And if we took all of the resources that's spent on neurodiverse assessments across West Yorkshire, we still wouldn't have enough money to bolster the system to meet the demand. Therefore, what we're looking at is what are we going to do differently? At the moment, there is a number of kind of pilot programs and innovations that are going on to look at providing services in a different way, and whether we can meet people's needs without the need for an assessment and diagnosis. So can we access resources and support for children in schools that doesn't need that label attaching to them? Can we just make this a needs-led approach? And there's a number of pilots going on and across West Yorkshire, and indeed there's a focus meeting, an event a week tomorrow in Leeds to look at this very issue. So I can't sit here and say that we have the solution right now. There are some challenges from a funding route for this, in that it is not part of the mental health investment standard. So there is not ring-fenced resource for this. There has been additional resource supplied from Leeds in the last 2 years to address particularly children's neurodiversity assessment waiting times. But again, that's against a picture of growing demand, so it's not met, it's not kept up with the demand. So I don't sit here with a solution for you today. What I can say is there's a significant amount of work to address this going on across the city, and to also raise the profile at a national level to see if we can get some additional resources attracted into this area.
Okay, thank you very much. I think it sounds like you recognise the real challenge for young people in terms of if it affects their schooling, if the assessment comes 3 years later, it's for a child, that's an eternity. I think you understand that point. So that's appreciated. If you could, it'd be helpful if you could just write a short note for the board about the work going on and send it to Angela to share. Is that okay?
That's absolutely fine. I'll do that.
Okay, I'm going to bring in Councillor Gibson next.
Thank you for spotting my earlier hand up, Chair. Appreciate that. Given what you've just said, and you've been really frank and honest about the situation that you find yourselves in. So I suspect you'll be equally as frank about the questions that I'm going to ask now. So I noticed from the report there isn't a lot of mention around learning disabilities and neurodiversity. I presume that does fall under your remit as SWIFT, doesn't it?
As Leeds and York Partnership Trust, yes, it does.
What's the difference between Leeds and York Partnership Trust and South? What is it? South and West Yorkshire Partnership Foundation Trust.
So it's the difference. We're a different hospital trust. We're a different NHS provider. However, at the West Yorkshire level, we work in the same integrated care system. So we do an awful lot of joint work. So we are working very closely with them around the neurodiversity agenda. We're in provider collaboratives with them around eating disorders, forensic services and children's services.
So what's your experience of specialist services for people with neurodiversity and learning disability? What's your not personal experience? I mean, what's being fed back to you about those services, specifically hospitals and other specialist services like locked rehab? Just an honest assessment of what's going on.
There's been quite a lot of work over the last few years to redesign the way services for people with complex learning disabilities that are sometimes associated with neurodiversity. And I think this is some of the challenge that we have at the moment is people with neurodiverse conditions. It does not necessarily mean you have a learning disability. If you have a learning disability, it doesn't necessarily mean you have that you are neurodivergent. So they're often seen as labelled collectively, but actually there are very different needs. That doesn't mean to say people with a learning disability don't sometimes have neurodiverse conditions. So we have reconfigured assessment and treatment services for people with complex learning disabilities. And there are now 2 units that operate across West Yorkshire. We moved the unit from Leeds and that went into Bradford and Wakefield, which is provided by South West Yorkshire Partnership and Bradford District Care Trust. And we continue to work in partnership with them. In terms of people with a complex rehab need, so these are people with very complex rehabilitation needs that often use multiple resources from different agencies and can be quite challenging to get on the right pathway to recovery. Again, there is a West Yorkshire service that is hosted by the Leeds and York Partnership Foundation Trust that is now working towards developing and implementing a new model of care so that we are able to support people with complex rehabilitation needs in the community, in their own homes, rather than them needing to be in restrictive hospital environments. So there's been some significant resources allocated to that through the transformation monies, through the new money that's come into mental health services over the last 3 years. And on that point of resources, I will just say that we have seen significant investment in services in Leeds and across West Yorkshire in in mental health services for people with complex and severe mental illness. And to be fair, it's the first time we've seen this level of investment, the redesign around the community mental health programme, the transformation programme, for about 30 years. And so it's allowing us to look at new models, new ways of working to support individuals' needs.
Thank you for that. And look, let me just caveat everything that you know, I understand the difficult situation that you're all in. There's never been parity between mental health and physical health, and indeed physical health and social services as well. And it tends to be sort of mental health provision and social services that are having to deal with the most complex people with learning disabilities, neurodiversity and mental health issues that are possibly in crisis and at risk to themselves and others. Now, it sounds great about what you're doing in terms of the community provision. And of course, we certainly did need more community provision. Nobody's denying that at all. But what do you think about how much provision there is out there for people that community provision isn't adequate? So for people that do need to be in hospital, for people that do need to be in locked rehab, because my experience is actually that there isn't enough of that provision. And whilst a sort of left shift to preventative services is great in theory, sometimes it's not adequate enough to make sure that those people are safe, their families are safe and communities are safe as well. And they're sort of saying, like, okay, well, we've got community support. If it's not adequate and the beds aren't there, it's putting everybody at risk. And what you tend to see is people really deteriorate because they're just not getting the support they need. What they really need is to be in hospital or locked rehab, and there just aren't the beds there. So they end up going to, you know, Wales or down south or wherever it is, miles away from their family, and you see them deteriorate and the situation gets worse and worse. So I'm saying, you know, it's great that we've got that left shift, but I would expect you to say as well that we do need more beds.
So there are gaps in provision in some areas. So looking at people with complex needs, well, complex autism, we're doing some work around at the moment about what might some provision look like. What we're trying to do is look at, can we provide support to people in the least restrictive environment? So it's not necessarily about hospital beds and locked rehab. There is a move to probably not grow that capacity. So in Leeds, we have a locked rehabilitation ward for males. We don't have one for females. We have to outsource all of that work. So we're doing some work with our partners across West Yorkshire about, would it be more cost effective for us to provide a female locked rehabilitation unit? What we do need to do is provide more complex packages of care around those individuals in the community. And so the modelling work that we've done suggests we actually have the right number of beds, but we don't necessarily have the wraparound packages of care for individuals balanced in the right way at the moment. When we don't have that, what we see is those individuals come back into the acute care system and putting pressure into that system. And that's where we're seeing most people placed out of area at the moment. We have some significant challenges in Leeds, and again, we've done a lot of work around modelling how many beds do we need. If we get the levels of community support right, then we anticipate, well, we've calculated that we have the right number of beds. So it's what our focus is on, where our focus is at the moment. Sorry, that's my Lancashire accent coming out. Where the focus is at the moment is about focusing our attention on increasing that capacity around community care to prevent those people deteriorating, to keep them well and keep them at home, because we know a significant amount of crisis is preventable. So that's where the focus of our attention is. That's around the community transformation programme. We've got a similar amount of work on a work stream that I'm chairing within the mental health strategy that we've just renamed since the paper was written, the crisis transformation programme, because we're doing the same thing about increasing capacity, working with third sector colleagues to prevent those deteriorations. And then we've got the more specialist redesign programmes. So have we got the right number of beds? Probably is the answer. You're never going to get me to say we're absolutely 100% certain, because a lot of this is art, not necessarily science. So we've probably got the right number of beds, and we're focusing our attention on the right areas, but we know the challenges. We know that we've not got enough workforce. We've got significant challenges in the mental health workforce market. That's not a Leeds issue, that's a national issue. We really welcomed the Prime Minister's workforce announcements last week for the NHS about the additional numbers of training, but that doesn't solve our issue right now. So we're focusing on that, and we know, we need to move quicker and faster because of the challenges that we know face our population, that they die sooner, they have more physical health issues than the general population. I hope that kind of answers your question.
Could you tell me a little bit more about what that community provision looks like then, because it sounds great, doesn't it? People should stay in the homes, and we should support them to stay in the homes rather than go to some locked rehab or hospital. But when people are at crisis, where they really are at risk themselves and others, and the family just can't cope, and actually the sort of support that traditionally put in tends to be care agencies, specialist care agencies for people with that specialise in people with learning disabilities, autism, mental health, or whatever. But they struggle, and they can't be there 24/7, or even if they can be there 24/7, but they're still themselves are at risk. And therefore that placement is always at risk of breaking down, and the family can't cope, and they're just screaming out for actually some support that's going to be able to, some real treatment and support that just can't be delivered in the community. That's my experience of working on the front line of social work. So often the amount of cases that is the situation, and they just cannot get them the support that they need. So okay, you've said that we've got enough beds, perhaps, and we don't need that locked as much to increase our capacity in locked rehab. So what is the community offer? What is it going to be that's different to what we currently have at the moment that is leaving so many people vulnerable? And again, I'm going to say that I understand that you've got a very tough job and you've got my sympathies. I know you're doing your best in tough times when we've never had enough funding, but what is that going to look like?
Okay, so support packages around individuals with complex needs. I'll ask Liz shortly to talk about the work that we're doing in the community mental health programme, but in the complex rehabilitation service, we are partnered with third sector providers who employ key workers and support workers, and we have mental health nurses, community mental health nurses, who will also work alongside those teams with occupational therapists and psychologists. So they will put a programme of support around an individual, and that can be really intensive. They can be with them, they can visit numerous times in a day. They can spend prolonged periods of times with the individuals to help them rehabilitate and learn how to undertake the normal activities of daily living that many of us around this table don't think twice about, and can be quite difficult for them to for some of our individuals to cope with and to do. So they'll support them in that way, and there is a number of kind of programs that are psychologically based interventions that can be provided for people, and so the packages are tailored very individually around these needs, and they're evaluated to make sure that the progress is being made in the right direction. So that's the nature of the complex rehabilitation service. Once somebody's kind of, if you will, graduated through that programme, they would fall under the remit of the community mental health teams, and the aim there is to support them and to help them maintain their well-being. We work in the hubs, and Liz will talk about this in a minute. The partnerships are really important with not just other healthcare providers, but housing, with social care, with employment services, because it's all of those other aspects of somebody's life that will keep them well. So this is where the hubs offer this new opportunity of working differently. So.
Yes, so one of the biggest changes is bringing together what are currently separate bits of provision into a single integrated team, and that will bring a lot of efficiencies and free up capacity in those teams. So we've done analysis where we've looked at some referrals, and the same individuals have been referred to lots of different services because people don't know where to go for help. And that means that that same person might be looked at by several different clinicians, have different assessments. So some of that time kind of goes back into support people. There are some key principles of the model. So if somebody has a mental health need, they can be referred into an integrated hub. They can self-refer, somebody else can refer them. And we'll aim to do within, I think we're aiming for 5 working days. It is subject to workforce availability, but that's what we're working towards. So someone will have what we call an initial helpful conversation. We hope that that might help prevent some people going into crisis, because sometimes they just need to feel supported by somebody and that somebody's there to work with them. For some people, it might be what we call a brief intervention, where they work together on understanding what's going on for that person, what's brought them to that point, what are some of the things they need help with. And it might be a really simple intervention around some support from a third sector organisation or a community wellbeing connector or a social prescriber. It might be that they've got lots of complex needs, and it might be lots of different things relating to needing some psychological therapeutic support, housing needs, employment support. And so I suppose the gift of this idea of this hub is that you've got all those people and agencies working together with that individual to work out, in partnership with that person and their family and carers, what do they need to help them stay well? And that might be things like some psychological therapeutic interventions. We've put in a lot of funding into recruiting more psychological therapists and different types of roles, so we can offer group work as well, because sometimes that means people can get access to psychological therapy a bit quicker. We've expanded the input in terms of employment support and other social interventions. There are other key things that we have to do, so everybody will have access to a named key worker. So they'll have a continuity and a point of contact to work with them. Everybody has to have a personalised care plan that's theirs and they own. So what we hope that'll give is a greater sense of clarity about, personalised led care planning, somebody being clear, what are the interventions that are going to be offered to me to help me stay well. We'll need to work really closely with crisis services. So if somebody's needs change, how do we get them into the right service? Or if somebody's in crisis, how do we get them into that hub offer sooner? And we've also done lots of work with different citywide specialist services. So if I take perinatal, for example, or Connect, which is a specialist eating disorder service. So how do those specialist services support the teams in the hub in terms of upskilling people? But if somebody's needs change, how do we get them into that specialist service really quickly without somebody having to tell the story all over again, without it having to be a new referral? So lots of the changes might be about how teams work better together, which might not feel from an outside view or for a service user what's different for me, but actually the difference is that you get in people working together in a way that means you're not having to go to different people, retell your story. And we hope that will make things work more efficiently as well, which means we've got more time to care for more people.
Super, thank you very much. Okay, I'm going to move on to Dr. John Beale next, please. Thank you.
Thank you, Chair. Can I just start by going back to Councillor Gibson's question and your answer about neurodiversity? Clearly, we understand the difficult situation in which you are placed with more referrals than you can actually cope with. But as I understood it, what you were saying is we're looking at a way in which we don't have to do the full assessment and diagnosis and can perhaps find other ways of taking that forward. As I understand it, at least a number of those children who are referred for autism, neurodiversity, are referred because an assessment and diagnosis unlocks additional support within the education system. So I just wonder if they don't have a full assessment and end up with a diagnosis, if they're then losing out on the additional support which they really need, which may depend on that diagnosis. Shall I move on to what I was going to talk about? The findings of the survey, I appreciate that it wasn't a random sample and that the sample size was fairly small, and indeed looking at those who might be university students, the number of 16 to 25-year-olds was only 21, so it's a very small sample. But on page 37, it says most students felt that people who are facing challenges aren't treated fairly at their place of study. So my question is, we've all read and heard about several university students, not in this city, but elsewhere in the country, who sadly have committed suicide, and there's been no support for them, which hopefully then could have avoided that suicide. So my question is, what work has been done and or is being planned with the universities in this city to try and ensure that it doesn't end up with crisis which could lead to suicide? And the other question I'd like to ask is going back to crisis services, older adult crisis. I was slightly surprised it's only graded as amber, because when you look at the three measurements, one of them, percentage of people receiving a mental health crisis assessment in 0 to 4 hours, 52.5 against the target of 85%. I think that is a very clear red rating. And to some extent, you've probably answered the question I was going to ask, but I would just say that for some time in this city, crisis services have been recognised as not being as good as they ought to be. So I would just stress the importance of making sure that we do adopt some of the things which you've been talking about to try and push up that 52.5% up to hopefully 85% or even more, but at least initially approaching the target. Thank you, Chair.
Thank you. Just on the first question around young people, I think you covered it earlier when I asked the question. So if you just make sure you include that in the briefing point and then move on to Dr. John Beale's other two questions, please. Thank you.
If I may, I'll answer your crisis question first, and then I'm going to hand over to Liz for the student, the response to the student support. Yes, we are not meeting the target at the present. If you were to see the trend data, it would show that we were meeting it. The issue is absolutely down to workforce at the moment. And we have been working hard to recruit into vacant posts, to look at, different methods and approaches to make the roles more attractive to people, to encourage them. Again, there's been some reconfiguration within our crisis services. I don't need to give you the detail, but it should be that we start to see an improving position in the response times. So yeah, and you're absolutely right. The crisis transformation programme is focusing on those areas that have been repetitive in the feedback that we've had from service users about where the failings are in crisis services. So that's the focus of our attention in that crisis transformation programme.
I'll come in response to the question about the university. So Leeds Student Medical Practice in the Light Local Care Partnership is one of our early implementer sites, and that decision was made before I came into post, but I think that part of the reason for that was recognising the need around that population, and also it's quite a specific population in terms of its, the demographics and the need. So we've been working really closely with them in different ways. So when we started the work, we did a lot of mapping work to understand what are the different services provided by the university versus the NHS and other care agencies, and where there might be gaps. Leeds Student Medical Practice in the Light as a primary care network has been very proactive in using access to funding to put in new roles within at a primary care level. So they have some additional mental health practitioners. They've got a mental health practitioner specifically to focus on eating disorders and disordered eating, because they know that's an area of greater need in their population. We've been working really closely with the universities around their health and wellbeing offers. And we've put in place some new roles called community wellbeing connectors, who are there to work with people. They take referrals from the university as well as other agencies, and they're there to support people who might struggle to access services that are out there. So they can go along to groups with them, they can get them ready for certain appointments. As Alison said, what we need to do is make sure the links with the crisis work are really carefully thought through, so that we aren't create any gaps that people might fall through. And we've also done a lot of work around how do we strengthen the relationship between specialist pharmacy and psychiatrists to GPs to help them better manage people in primary care. So there's quite a lot of international students who might come having been prescribed certain types of medication that GPs might be less familiar with or able to manage. So we've improved the psychiatry input into primary care to help them work with people around the medication needs and things like that. Yeah.
Thank you. Okay, thanks for that. Councillor Ritchie.
Thanks, Chair. I just want to dig into the community mental health transformation consultation. So I had a little bit of involvement and experience of that. First through the LCPs, where I think initially they set up these, well, the 90 days brainstorming sessions and or something. And my view of those, I mean, I don't want, you know, you'll give me your view, but was they were a bit rushed and didn't seem as organised and well coordinated. And then I also had some quite extensive involvement in the Leeds Involving People consultations, and they had a small working group with lived experience, and we had a workshop there. You may have been at that. I'm not sure yourself, Liz, but to me that went really well. So my question is, what did you get out of that, would you say? And were there any significant changes or lessons learned, how you might approach that differently?
Thank you. So the 90-day, it was called 90-day learning cycle, which is an improvement methodology that Leeds and York Partnership Foundation Trust have been using, and it's meant to be a focused sort of scan of the evidence around different models and things like that. I think the learning was that was too ambitious, and we were clearly never going to crack something that complex in 90 days. It wasn't 90 days either, because we had to pause for 2 months because it was when Omicron hit, so we had to pause the work. What it did give us was some really good principles that were evidence-based around personalised care planning and a key worker role, and how multidisciplinary teams work well together. So we got from that some principles, and then we went kind of wide again and had lots of design workshops over last summer and early autumn, where we got all partners and people with lived experience in a room and looked at different bits of provision in the pathway. Went back out to the local care partnerships and said, this is what we're thinking, what do you think, give us your feedback, and kind of built that into the model. I think the biggest learning is this stuff really takes time to do it well with all the partners around the table. To do genuine lived experience involvement and care involvement takes time. It's not easy, but I think what we're trying to achieve is a culture change. So investing in the relationships now feels important, and actually a lot of the feedback we've had around that has been really positive, and lots of good work around trauma-informed care as well. So yeah.
So will there be ongoing discussions and getting feedback from those group, like the Leeds Involving People group? Because some of the regular meetings seem to suddenly stop for some reason. I didn't really understand why, but as it gets implemented, because I know one thing that was brought up and it is referred to in here is the trauma service at the moment. I mean, I've had casework based on it, and people are passed from pillar to post, from primary to secondary and back again. And that's certainly been picked up, hasn't it, as a way forward. But that's a question on, you know, feedback as things develop from that specific group of lived experience people.
Your microphone, please. So thanks, Lynn.
Thank you. There's a few bits to that. So we're aiming to start piloting those first 3 hubs from autumn. So we're working with the local care partnership team at the minute to say we need to come back out and give people an update and work with people, and then we need a kind of regular feedback mechanism. In terms of lived experience involvement, because because it's so important we get this right, we have put some investment into resourcing that properly. So there's a lead, an involvement lead, who's employed by Leeds Involving People. They formed an involvement network so that there's a group there who can meet and be a sort of reference group, be involved in different working groups. They need to grow that. It's not as diverse as it could be in terms of its membership. There are now 4 additional involvement workers, each of who sit in a third sector organisation with the relevant sort of specialism. So there's a worker looking at carers' needs, a worker focusing on racialised communities, a worker focusing on working age and younger adults, and a worker focusing on older people. So we want to make sure that we keep having that conversation, go to the groups where we need to understand any particular barriers to access or different types of support that we might need to provide in a different way. So that's an ongoing dialogue, really. Healthwatch have been providing some additional support recently as well around strategic input, so there will be an updated involvement and engagement plan coming through our programme board in the next couple of months. But any feedback separately or any questions, more than happy to take them, and I can put you in touch with the relevant involvement lead.
Another question now, if nobody else is waiting yet. Is that all right? So it's on to the next topic around the priority number 1 and that sort of early intervention to stop the escalation. In late 2020, admittedly that was during COVID, we were asked as ward councillors through our LCP to do a bit of a week survey, not just us but other partners, every contact that they had, to ask them if they were having an impact on the mental health. And during the course of that week, I had 22 separate inquiries that had, I'd asked them how they're feeling about it, and they'd say, oh, it's making me depressed, or I'm feeling down about it. So I recorded all those. And 22 people referenced mental health and mood. Now, 9 of those related to things, if councils were properly funded, we'd be able to solve. There were housing issues, from overcrowding to repairs and so on, and antisocial behaviour issues as well. Until we get to the bottom of those, we're just firefighting, aren't we, with mental health, and we're stopping that escalation. And I think we need to address the Westminster politicians need to get a grip on housing policy, because housing policy to me is a crucial factor in all the outcomes that we seek, be that in education for attainment for children, in health, and in health, general well-being as well. Now that's, as I said, beyond your control. So this additional resource, for example, with the Connect, I think they call them City Connect workers or whatever that have been put out there, they come up to the same problems that we do. There's a housing problem. Often they refer back to your local councillor to try and resolve, but it's out of our control because there isn't enough council houses. The so-called affordable housing and the government's Help to Buy scheme, which subsidises billion-pound property developers, aren't affordable for people. So we're really tackling this with one hand behind our back, as far as I'm concerned. It's out of our control. But that's the crucial thing. It's like the foundations, isn't it? To get a grip on a lot of the mental health issues, we need to sort out those core services, and that means funding local authorities adequately. And just to say, on those contacts that I had, it's interesting that it reflected, I think I had a 75% women contacting me out of those 22, which ties in well with your cohort characteristics. And that's the other thing that I'm sure will be addressed, but the lack of male mental health and the lack of engagement, be it presenting at services and responding to consultations. I suppose that was more of a comment, Chair, but I think it needed saying.
Yeah, thank you. I take that as a comment. Thanks, Kevin. Councillor Ritchie. I think you're absolutely right on the housing and I don't think the service look like they're disagreeing. Okay, I'm going to bring in Councillor Hartbrook next.
Thanks, Chair. Councillor Gibson spoke very eloquently and very passionately about clients that were at the very extreme end of need, almost kind of at the point where I was too late, but actually when they're already in crisis. Picking up to some extent what Councillor Ritchie was saying around a lot of mental health. You know, I think as a society, one good thing I would say is we talk about it more. To some extent, the taboos around talking around mental health have come down a lot. There's still a long way to go. And I think, the comments that were made around, around the number of males who are reporting mental health issues versus females, I don't for one moment think that that's gender. I think it's more to do with propensity to step forward and to seek help. But irrespective of funding, it's clear there is more need out there, because with identification and with removing taboos, people are stepping up and saying, actually, yeah, I'm not all right. And whether that's because of housing, or whether it's because of jobs, whether it's because they're worried about climate change, or whatever else is weighing on them, and sort of giving them that, going from sort of swimming to floundering, help is needed. And I think for many of those, I mean, a lot of the work that you do is when people are already, I guess, a good way through that journey. But there's a lot that I think can be done with diverting people who it's more situational mental health. It's mental health because of what's happening to them and how their robustness in coping with that, rather than, I suppose, anything kind of more clinical, I would say. Now, I know organisations I've worked with and businesses I've worked with, again, as part of the mental health agenda, are putting in more support networks and more counsellors, and often those operate outside it's not medicalised, it's more companionship or advice or kinship. And I just wonder, from your services perspective, are you doing everything possible to leverage the resources and capabilities of others to make sure that different organisations are sharing best practice, but also, to be quite frank, to make sure that the ones that come to you are the ones that have to come to you, rather than the ones that could be dealt with either by, whether it be counsellors or by somebody with some training. I'm thinking like kind of mental first aid, rather than kind of, by the time it gets to you, you're kind of mental heart surgeons. And I'm trying to think how you kind of, the ones that could get a lot more serious if it's not dealt with, get dealt with more at a community level or at a business level or an organisational level that isn't taking resource, using up your what are quite clearly sparse resources. Thanks.
Thanks. Just before you come in, also there's definitely some of the partnership work from page 56 onwards on the pack, but I'll let Alison comment as well. Thank you.
I'm kind of looking at Victoria, because I think you want to come in, do you, on this point? You're quite right. Leeds and York Partnership Trust are very much focused on people with severe mental illness, those at kind of the more severe end of the spectrum. There is a whole spectrum of work that goes on to support people with mild to moderate mental illness, and that starts really with the work stream 1 that I'm sure Karen will talk about, but there's the work that is going on, or the services that are provided by Leeds Community Healthcare, which is the talking therapies, which is the new name for what we affectionately refer to as IAPT. They likewise have seen a similar growth in referrals, are struggling with some of the capacity issues, but actually looking at their data, they are doing reasonably well at some of that access stuff and that recovery, the recovery rates that are required. But I think this is where the role of social prescribing, of employers being good employers and that kind of thing it needs to be paid attention to. Are we doing everything we can within secondary care services? I like to think we are. There's possibly more we could do, but we are there to support that whole volume of activity that goes on at that end of the spectrum that is about preventing people's mental health deteriorating to the point where it becomes necessary for them to seek help from secondary care mental health services.
Karen, do you want to come in next? Thank you.
Thanks very much. Just to come back on a couple of the points people have raised previously, I think I'll try and work backwards because I can remember it easier that way. Councillor Hartbrook first about training and stopping people kind of getting further along the pathway around towards crisis. What we're really keen to do is keep people well in the first place. So it's not just about people with mild mental health. Actually, I'm further upstream than that as well, for people to be able to not only talk about their mental health and well-being, but actually think about the things that might improve that. We know what the risk factors are around mental health. Health inequalities is an obvious one that people haven't really talked about this afternoon, but there's a huge disparity around mental health and inequality that we need to think about. So focusing some of our work in those more areas that really need that. We talk about the mental health of men, and we do have a good support network in Leeds around men's mental health unlocked. And there's quite a number of organisations, and certainly from a public health perspective, we've funded quite a lot of men's organisations through small grants to work with men to think about how they start talking about mental health, but actually talking about their feelings and much more broadly. So there's quite a lot of work that we're doing across the city, very much upstream around that preventative approach, around getting people to think about their mental health. Not everybody uses those terms. Being You Leads, our new approach, is we don't use the word mental health service. A, it's not a service, and B, we want it to not give it the kind of recognition that this is a mental health service, because we know that will immediately put people off. It's about people being able to be more thinking about and promoting their own health in its broadest sense. And coming back to Councillor Ritchie's point about those wider factors that impact on someone's mental health. We know about all those, and yes, we have to still try to mitigate them where we can, but certainly the work that we're beginning to do around the work that Michael Marmot promoted around actually giving people not only a best start in life, but actually tackling those wider things that we know impact on someone's physical and mental well-being. So we need to do both, I would say. We need to do where we can to support people who may be struggling for whatever reason, but also thinking about that broader, how do we change things for the future so that people don't have to end up in some sort of mental health service, which for all the reasons you've been outlining this afternoon, make it really difficult for someone, whether they actually even seek that help in the first place or until it's too late. So for example, my work around suicide prevention, we still know that the vast majority of people who take their own life are men. We still see that. So a lot of our work is focused on focusing on supporting men around that agenda, and also students. We know students are more likely to take their own lives. So making sure we have preventative approaches to look at that as well, looking at both risk factors, the individual risk factors, and those groups that are at highest risk. So I'll leave it there, Chair.
Thank you very much for that. Yeah, the really appreciate those facts. The biggest killer of men under 45 or 50 is actually suicide, isn't it? And so it's a big crisis point. Victoria, do you want to come in as well?
Thank you, Chair. Just briefly, just to echo Karen's comments there, and thank the Councillor for his question. I think it's
it's such a fundamental point that we know that around 80 to 90% of mental health is created in communities. We can see the demand for services is growing beyond measure, and we will never solve the problem by services alone. Service colleagues are nodding there. You know, obviously services have got a critical role to play for the people who absolutely need them. So there's something about getting that balance right. So I really welcome the comment. I think the other point, to go further on that, some of you may be familiar with some of the published evidence recently that also says not only is it not going to solve the problem, but it's fundamentally damaging to individuals who are living in conditions that are harming their physical and mental health, and then to actually locate the problem with them. As you know, so they are then the problem. There is something the matter with you. And I think that we really run the risk of actually compounding inequalities and people's ability to recover. And again, going back to the Marmot City approach, if we send people back into the conditions that make them ill in the first place, then we never solve that problem. So I think in Leeds, what we're really proud of is the fact that, you know, Karen's leading a work within the strategy, that as a city, you know, we can always do more, and it's always hard to make the case for prevention, particularly in mental health, because we often default to services more so than in physical health. But the fact that we've managed to carve out and hold on to at least some resource to do the work that Karen's described is an important bit of the strategy, and I welcome the opportunity just to talk about that. Thank you.
Thank you very much, Victoria. I think very well made points. Okay, I'm going to bring in Councillor Farley next.
Thank you, Chair. So I've got two sets of questions. We'll start with workforce first. So we had reference earlier to the new NHS long-term workforce plan. If only the government had have brought that in about 13 years ago, we might be all right today. I suppose my question really focuses around what does the local workforce plan look like, and what have we been doing to address the significant shortages within the mental health workforce, and what are our plans for the future of that workforce? Obviously within that, we don't have enough staff as it is. So are we looking at the shape of the workforce? Has there been a shift in roles? The development of new roles, ensuring that staff are working to the top of their register, looking at effective deployments within across all the different partners. Obviously, as we've now got ICSs and much more integrated systems, which is obviously welcome following the total fragmentation of the system 10 years ago, or just over 10 years ago. So yeah, can you tell us a little bit more about the workforce and where we're heading?
Thank you. I welcome the opportunity actually to talk about this. It's something that's paid great attention to, certainly within secondary care mental health services. I'll start with the day-to-day shortages that we experience, because we have gaps in posts, and that is across all the different professional groups. We've done the immediate actions are around utilising bank and agency, and we've done an awful lot of work to reduce our agency spend and increase the number of bank staff or temporary staffing that we can call upon when we need them to, that's been quite successful. So we are able to safely run the services as we need. We've had some particular challenges in our community mental health services, and we have redeployed staff from within LYPFT who have a clinical background that are in non-clinical roles now, and we've redeployed a number of those into our community services to ensure that we're able to provide the access and the assessments as needed to the teams. So those are some of the immediate short-term things that we've done. In terms of then our long-term workforce plan, it is multifaceted. Some of the schemes that we've had great success with are around the apprenticeship scheme. So we have maximised our apprenticeship levy and the number of apprentices that we have in the services, and that includes into clinical roles, into healthcare support workers and other roles like that. We continue to run a number of kind of recruitment campaigns where we have worked with colleagues in the council and colleagues from across West Yorkshire to advertise about, Leeds and Yorkshire being a great place to work and live, and to make the packages around those posts more attractive, incentives, golden hellos, that kind of thing, refer a friend scheme, etc. And we've had some success with those, but part of the challenge of that is we're fishing in a small pond at the moment. So we recycle a lot of workforce around the different mental health providers. Another area that we've looked at is developing those new roles. So, for example, one of our challenging areas of recruitment is in consultant psychiatrists. So we have developed a number of specialist roles and developed nurses and therapists into specialist roles where they can take on some of the responsibilities of, that were previously undertaken by medical staff. And the other area that we've had great success with is partnering with our third sector colleagues across Leeds. So we have a number of workers now from organisations like Touchstone, like Community Links, or Inspire North as they're now known, where those key workers work alongside and in our part of our community mental health teams. They take on key worker roles. We're looking at care coordination being passed to them and that kind of thing. And we've had some real good success with that. The workforce challenges are knocking on into the third sector. So whereas previously they had no issue recruiting staff, they're now beginning to find it more challenging to do so. And so those are just some of the schemes that that we're undertaking. The challenge with all of those schemes is they are great, but sorry, I should mention that we are part of the Leeds One workforce as well. And in fact, I think that is still chaired by Sarah Munro, who's our chief executive. So we're working with colleagues across Leeds on that development programme as well. The challenge is that the rate of delivery of the new workforce isn't at the rate of attrition that we've seen in recent months and years from mental health services. We've also got things like retire and return schemes and etc.
Just to add to that, in the context of community mental health transformation, we're doing all of the stuff that Alison's talked about, but it's also about how we retain staff, not just how we recruit them. So we've been doing lots of work thinking about what do career pathways look like, so people feel like they've got somewhere to go, and we've put a lot of thought into investing in what we call recruit to train roles, so that we train people, but then we keep them in the Leeds system essentially. Thanks.
Thank you. I'm just going to come back on this before I go on to my next questions. I think you've sort of answered one of my follow-ups, which was around like progression, because obviously you talked about the apprenticeships, but once you've got the apprenticeship, where do you go from there? I suppose again, the key issue at the moment for a lot of the NHS workforce is around, well, in terms of retention, is pay. The government is completely refusing to acknowledge that quite a lot of our NHS workforce has had a pay cut over the past 13 plus years. And the refusal to remunerate people properly for the work that they're doing in the context of in the context of kind of increasing workload, increasing work pressures, is clearly driving people away. Band 5 nurses on around, well, just under 30,000 at the moment. You could go and work in PR, and it's for similar sorts of money without the additional stress and pressure of the shift system. So do you think that that's impacting on your ability to attract to the workforce? And I'd also just ask, what does the international workforce look like? Obviously, there've been a number of reports looking at how nursing has been increased over the past several years, and quite a big chunk of that is coming from overseas. So what does that look like within the context of the Leeds system?
I'm not sure I want to comment on the pay thing, if I'm really honest. I suppose, and this is a personal view, and I must caveat that the challenges with any pay rise that comes, there isn't an increase in the funding pot to do it. We get an inflationary uplift usually into public sector services each year. If there's a pay increase, it has to come from within. So then there's a consequence of that balancing services. In terms of the international recruitment programme, we've done that jointly across West Yorkshire. For mental health, it's not been that successful, I'll be honest. There has been some small numbers of people come from abroad, but there isn't a particular plethora of people abroad. There's obviously a challenge in mental health workforce internationally as well as nationally, so we've not had a great deal of success, and there has been some issues with integration of some of those international workers into the service as they've arrived. So while we will keep on trying with that approach, we're not relying on that as being an income of an incoming workforce numbers of any significance, really. And we really ought to be concentrating on growing our own workforce, and so those are the schemes that we are majoring on.
Yeah, thank you, Chair. Thank you. I suspected you might not be able to, or prefer not to comment on that, which is why I laid the politics on heavy there. I suppose but my next question is more around kind of the relationship between the system and patients, because there was the reference made to kind of neurodiverse services and assessment having a lot of issues in terms of kind of people. Obviously, an increase in demand has led to an increase in people waiting. How are these challenges being communicated to patients? And what I'm thinking is kind of if waiting times are increasing, are people being informed of like how long they can expect to wait? How has this been passed on? Is there proactive communication around these issues?
I would like to say there is. But we have been looking, at the moment, we are developing communication to go out to GPs to inform them of the waiting times, because they make the referrals into the services. So when the person is sat before them and they're saying, I'll make the referral, we're going to be providing GPs with more up-to-date and accurate information about what the current waiting times are. And it's at that point that then an individual may choose to seek an assessment from an alternative provider.
And if that individual kind of has been waiting, are they able to go to the alternative provider kind of within that period, or?
Yes, they are.
Thank you very much. Okay, can bring in Councillor Anderson next, please.
Thank you, Chair. I'm going to skip a lot of what I was going to say because other councillors have asked similar, and I've had the answers to a lot of the stuff I've written down. But I've just noticed I'd written down social prescribing, and I've just noticed in Appendix 2, there's a number of different grants being awarded to various organisations. What sort of, how do we review whether this is working when we give people these grants? How are we making sure that what's being done is leading to the outcomes that we want? Thank you.
Okay. So there's two ways really. So the grant funding is being led jointly by Leeds Community Foundation and Forum Central. So they've got a thorough evaluation process in place around that. And then we're also evaluating the whole of the Community Mental Health Transformation Programme. It's part of a West Yorkshire evaluation over 2 years. So on both those fronts, we'll be looking at the effectiveness of those grants and the value for money and the impact.
Are you happy, Councillor Anderson?
Well, is there anywhere that the outcomes are written down so that we can maybe review them at some point to say that, you know, this number of people were helped and we've seen less people coming through to need more serious interventions and, you know, things like that?
So for the grant specifically, I can request that information if that's helpful, and we can pass that through in terms of their evaluation framework. For the programme overall, we have the spec in terms that we've got some outcomes that were co-designed, and there's a series of indicators under that, and then we've got the information about what niche the evaluation provider will be doing. So I'm happy to pick up with yourself around whatever's needed to be passed on in terms of information.
Thank you very much. That would be helpful. Okay, I'm going to bring in Councillor Taylor next.
Thanks, Chair. As Councillor Anderson, most of my questions have been asked and answered, but I'm just going to comment. I don't expect an answer from these questions. What I'm going to say, you talk about you work with agency. The agencies I was expecting you to work with is universal credit, housing, environmental, because those is the thing that triggered mental health. Councillor Gibson, Councillor Ritchie highlighted housing. All these third sectors are amazing. I support third sectors 110%, but their sessions is just for an hour, half an hour, 2 hours per session. When they go back home in housing, they've got dams, they've got mice, they've got whatever going on, their mental health kicked in back. You mentioned food banks. When we didn't have food banks, or we never have food banks, how would they cope? These are the things. I've worked in mental health all my time. Has it changed? I don't think so. The only difference, what I think, is we talk about it more. And there's so many ideas in black and white, but it's not in action for those individuals. And I honestly think we need to look at the agencies that we work in with. We need to look at housing, universal credit. Those are big issues. I've got 2 young people that came to me, and it's a shame to see where they live, how it's going, ring universal, and that make it worse. They came out of hospital, they went in a state, and they came back home in the state. And those are the issues we need. As Councillor Anderson says, we are spending so much money in these agencies. We need to look at the environment. We are locating them in housing in deprived area, for instance, Chapeltown areas where they can get drugs, alcohol, what contributed to mental health. We need to look at the environment where we put in these individuals if we need to help them. And yeah, we just need to do more for what we're doing, especially to our young people. Just be careful where you're putting these young people to live, the environment they're around, and so on. Thank you.
Thank you very much, Councillor Taylor. Victoria, do you want to comment on that?
Well, only briefly to thank Councillor Taylor for her comments. I think this is the conversation. It's really helpful to have the conversation to look at the way we look at mental health and which would inform the way we respond to it. Karen, in her introduction, talked about really understanding the protective factors that we know, if we've got these in place as a city, keep people mentally well. and also the risk factors we know actually undermine their mental health. So I think that, like we said before, alongside clinical services, because of course we have a cohort of people who will always need clinical services, we need this joined up approach of all the things that Councillor Taylor's just outlined, because we're over medicalising the agenda, and we'll never solve the problem by over medicalising the agenda. So I do welcome those comments which feed into the work that we're trying to do as a council and all the things that we can affect that make a difference to all those protective factors. So I know it's a huge agenda, but thank you for your comments.
Tony?
Yeah, I think one thing that's been really interesting to reflect is the amount of times that housing has come up actually in this conversation. So I think we've discussed at previous scrutinies when we've gone through things like the health and wellbeing strategy, how we prioritise in housing and health. We've got a breakthrough programme. It's part of the Marmot work, but it's not brought out really clearly in the current mental health strategy, even though there are a number of actions around mental health and housing and additional support and working with third sector organisations. So it's maybe one thing we can take back to the mental health strategy group and actually refocus on that as an area and be clearer about some of the things that we're doing. So likewise, I thank Councillor Taylor and other people for that comment. Housing is so important at the moment, and it's such a challenge, isn't it? Not just sort of paying for it, but the quality of housing, the damp, and the condition that a lot of people are living in, particularly in deprived areas.
Okay, thank you very much. I think I'm going to sort of summarise and try and wrap this item up a little bit now. Sorry, I didn't see you indicate, Councillor Anderson.
Sorry, Chair, is that all right? Thank you. I have a question around what the strategy is doing to make sure that cross-authority work, what work is being put into that, as, for example, mirrored council services to make sure, for example, if someone is in Bradford and they've recently moved from Bradford, I'll use an example of a constituent of mine who, I'm in Guiseley and Rawdon, which is very close to the border of Bradford. This person needed crisis support, and they had previously been in contact with myself, but they moved just over the border into the Bradford Authority, and we put everything in place, got in touch with referred them, and then we got an email back to say that because they were still registered with a Leeds GP, then it kind of, it just in respect to the term people being bounced around the system. I'm just wondering what work is being put in place to make sure that the council services that are mirrored with neighbouring authorities, what work is going into those to make sure that they are working together in the best they can be. Thank you.
When you live in the border areas, life can be complicated because the NHS is based on registered GP populations and local authorities are based on residential. So we depend on having good relationships across the borders with our local authority colleagues and our NHS colleagues in order to try and resolve these situations around individuals. If I'm honest, I can't answer with any authority right now about any specific pieces of work that are looking at kind of those cross-border issues. What I do know is we sort quite a few of them out on an individual basis. But I'd be happy to go away and have some conversations with colleagues in the local authority, within Leeds City Council and Bradford, to find out if there's any specifically. I don't know if Caroline might be aware of any specific initiatives.
Yes, Karen.
Certainly, from a commissioning perspective, we work together with commissioners across the region around any benefits there might be to working to manage the market and develop the market for provision. So equally for mental health services, supported living type arrangements. But
probably less so the community-based and preventative services, to be honest. We will work with our local community organisations, but not across boundaries. But if we think that there might be smaller numbers of people who need more complex packages of support, then we absolutely do work across the boundaries. Often, though, what happens is that we develop services in our own local areas. We have respective hosting facilities, so we might fund a placement, a supported living placement in an area outside of Leeds, and there'll be a mutual arrangement, but that's probably as far as it goes.
Thank you, Chair, for just coming in. Thank you. I think just to pick up on a point just that was made in the initial answer, I guess living in the border areas, if life can be complicated, I guess we don't want to make it more complicated for people whose lives are already significantly complicated. So if there was any scope to look at that, how we work together better, because I mean, in this instance, it was someone who needed quite quick assistance. So sometimes time can be critical in these instances. Thank you.
Thank you very much for that. Yes, I'm going to try and wrap it up. Take two. Just like to comment, also supporting the comments that have been made about housing, and Victoria, I think, spoke well, was if you get sent back to what's making you ill, that's not going to solve the problem. We've seen some trial stuff around prescribed heating in parts of my ward. And again, we're seeing that kind of level of, I guess, deprivation. I don't like the word, but is the reality for some people in Leeds, and that's really tough. But that's part of the inequalities of health and mental health linking to health outcomes. My question, I had a question around resources, the challenges, and the first one is resources. And I think the likelihood of this plan being achieved is all about whether the resources are there. And so I guess the challenge for both public health and the NHS is to keep this as a priority. And I think we'll see later on with additional paper, which is one of those challenges why it happens. I think we've agreed to get some extra data. After the meeting, we talked about something around assessment for children with neurodiverse challenges. I think that's really important. I think we'd like some data around the cross-border issues. I think that's also really important. And then I think there's probably something around, so if you talked earlier on, Councillor Gibson talked about specialist beds. Was there anything data-wise that would be helpful there, Councillor Gibson? Sorry to put you on the spot.
Yeah, I think if there's any, what data you use to analyse that we have enough beds, specialist beds for learning disabilities and people with, say, neurodiversity, but complex autism, ASD, and any decision papers you've made about that, so some analysis. And you mentioned as well that you're increasing essentially the intensive support services or intensive support teams, and that's a name that I came into contact with when I worked in a neighbouring authority. I'm sure they may have different names, but
Sorry, I accidentally turned your mic off. Sorry, really sorry.
I've got to finish the question anyway. Intensive support teams, you said you're bolstering those, so it'll be good to get some additional information about how exactly you're bolstering those teams and what your decision-making process was in relation to beds as well.
Yeah, so that's the third point. And then the fourth point was Councillor Anderson's point about data on how we measure our third-party suppliers. So I think probably set quite a bit of additional work there. So appreciate your time. We've been going for an hour and 40 minutes. So I'm going to propose we have a 5-minute comfort break. We also need to swap some chairs around. So please be back in your seats and ready to go in 5 minutes. Thank you. We're about to start again, just so you know. Okay, thanks everyone. Welcome back. We are live again. So the second substantive item of today's meeting is the Healthy Leeds Plan. Very pleased that this is coming today. I had thought Tony was going to introduce it, but I don't think he is. So can we start by the new people at the table? Can you introduce yourselves? And then I'm assuming one of you will introduce the paper. Assume we've already read it, but if there's anything you want to draw out, please do. Thank you very much.
Thank you very much, and thank you for inviting us today to talk through the Healthy Leeds Plan. My name's Catherine Sunter. I'm Head of Population Health Planning at the Leeds office of the ICB, and this is my colleague Jo.
Hello everyone, my name is Joanna Howard, Population Health Outcomes Development Lead for the ICB in Leeds.
As I say, thank you very much for inviting us along today. We're just going to outline few of the key aspects of the Healthy Leeds Plan and the paper, and then obviously welcome comments and questions afterwards. I think it's really important to set out what is the Healthy Leeds Plan, and the Healthy Leeds Plan sets out the health and care contribution towards delivery of a vision in the health and wellbeing strategy for Leeds to be a healthy and caring city for all ages, where people who are the poorest improve their health the fastest. And I think that context is really important to understand. The health and wellbeing strategy is wide by necessity, covers a number of areas, including community safety, etc. Whereas this is the health and care plan, the Leeds Health and Care Partnership contribution towards delivery of that health and wellbeing strategy, which equally is in the process of being refreshed. The plan sets out our high-level ambitions for improving health outcomes for both the people of Leeds through our two goals, which you will have seen within the paper and in the plan, and at a population level through our population outcomes framework. And in that sense, it might look slightly different to kind of traditional health plans that you might have seen that might perhaps be structured more in terms of points of access, such as primary care, etc., rather than population, which is a perspective that our plan in Leeds takes in line with our system commitment to a focus on populations and population health planning. And by population level, I know population will mean lots of different things to different people around this table. I mean, our 9 mutually exclusive segments in Leeds. So we have children and young people, healthy adults, maternity, long-term conditions, cancer, severe mental illness, learning disabilities and neurodiversity, frailty and end of life. The Healthy Leeds Plan doesn't describe everything we do as a health and care partnership. So there'll be improvement plans and change programs within each individual organisation and sector. But what it does describe is what we come together collectively as a Leeds Health and Care Partnership and system to achieve. And it's been developed with support from many people across the system. And again, I always want to thank everybody for their time and energy and support over the past few months in developing the plan. You have received a copy of the draft plan and a cover report, and the draft plan was signed off by the Leeds Committee of a West Yorkshire ICB last Tuesday, and it's going to the Health and Wellbeing Board next Thursday. Jo will go into the detail. The plan is part of whilst it's something that we do in Leeds, our Healthy Leeds Plan has also had a dual role of our submission to West Yorkshire as a joint strategic plan. And so we've been really under kind of time pressure to complete this also, but any comments from today, any comments from the ICB that we received last week, and any comments from the Health and Wellbeing Board next week, we have been given some additional time from West Yorkshire to be able to make those amendments if necessary. One of the first areas we want to highlight and what the paper focuses on is the approach to setting strategic system goals. The original Healthy Leeds Plan was signed off by the system in 2021, and it had a number of what we called strategic indicators. And by strategic indicators, we meant measures that as a system we were looking to have an impact on and achieve. And last November, when we reviewed the approach, we recognised that these weren't working as well as we'd hoped. They weren't really supporting us as a system in prioritising as much as we might have liked. In addition to that, as you'll have picked up through the Healthy Leeds plan, we have a number of population and care delivery boards, and a number of the measures of those measures have now been subsumed into the population's outcomes frameworks. So we recognise that these weren't supporting us in prioritisation at a system level as much as we wanted and didn't necessarily feel owned. So this was one of the first areas that we needed to focus on. In addition to that, when the Healthy Leeds plan was agreed in 2021, following that we had some engagement with the public also on the nature of the strategic indicators, and which were able to feed into those conversations. And also at the same time, we were having conversations with the public on at a population level on population outcomes and what were important for those populations. So that they've all really contributed towards the shaping of our shared system goals. The one thing that everybody said to us across the system was that we actually have too many goals, we have too many things that as an NHS is asked for us, and many of those things come down from a national level. And actually, if we're setting out what we're looking to achieve in Leeds, it needs to be really clear, it needs to be owned, and it needs to be something that we can all understand and will apply to all partners and really support us in prioritisation, which is why we've moved from quite significant number of strategic indicators to 2 system goals. And we work with a number of partners, boards, groups, etc., in developing these goals. And as you'll have seen from the paper as well, it was they were also shaped by some international evidence, looking at particularly at the work of the Staten Island system that achieved quite significant success at having a smaller number of system goals, and that's something that's based on kind of international and national evidence. But it was also important to us that the goals reflected the financial climate that we're in, and through focusing on areas of unplanned utilisation that drive high cost, we feel that's probably one of a much more realistic approach to take in this plan. Also our original Healthy Leeds plan, some of the comments we had was it wasn't explicit enough on how we're going to reduce health inequalities, which clearly is important to us as a system at the heart of what we do. So one of the things we've done is focus these goals particularly on IMD1, so there's that really clear link to health inequalities. By reminder, the goals are reduce unplanned care utilisation reduce preventable unplanned care utilisation across health settings. And in terms of measures, we're looking at unplanned utilisation in bed days, A&E attendances, mental health unplanned bed days, and crisis attendances, taking a population approach that's focused on identifying the root causes, and also a second goal of increasing early identification and intervention, focused on the 26% of the population living in the 10% most deprived areas nationally. So now I'm going to hand over to Jo, who's going to talk us through the broader purpose of the plan and the next steps.
Thank you, Catherine. As Catherine's mentioned, the Healthy Leeds plan does have that dual purpose. So not only is it our health and care system plan, but it's also our contribution to the West Yorkshire Joint Forward Plan. And that's stipulated within the NHS National Planning Guidance for 23-24. And that places a statutory duty on West Yorkshire to produce a joint forward plan, incorporating local plans on how we intend to meet national, regional and local priorities. We felt it was really important within Leeds that we didn't have 2 separate plans. So we really wanted our joint forward plan to be the Healthy Leeds plan. And that plan will form a chapter within West Yorkshire. We've been working with West Yorkshire colleagues on this, as well as the other places across West Yorkshire, throughout the whole of the development of our plans. Leeds plan is unique across West Yorkshire in terms of the approach we've taken this year, as well as our focus on populations. And it's been received with positive feedback from the other areas, specifically our ability to, as a whole system, to agree on such a small number of priority areas and those 2 system goals. Current thinking from NHS England is that the joint forward plan will need to be refreshed on an annual basis. We envisage within Leeds that the strategic element of the plans, the goals, should remain for the next 3 to 5 years, unless there's a real reason to change, and that the activity to meet those goals, the priority areas that have been identified and the activities to support that will be reviewed on an annual basis. Refreshing the plan will also provide us with that helpful point of reflection, so allowing us to consider as a system what progress we've made in terms of meeting those system goals and what more needs to be done and where that resource needs to be focused. So in terms of next steps, whilst the plan is written, it's now that delivery is really important and making that step change that's required as outlined within the plan. We know that every partner and sector within the wider Leeds health and care system has a role to play in terms of delivery on these system goals through the everyday work that we do. But we also know from partners that a partnership-owned plan doesn't necessarily always get the traction that we might have hoped, because we just try and do too many things. However, a key element of the plan is that identification of those small number of priority areas that will impact against the system goals, and that we're committed to delivering through either the population and care delivery boards, and local care partnerships play a real key role in this. So one area within the plan that's been highlighted in terms of a priority area is the Home First programme. We're also currently working through the other priority areas. We're working really closely with the Partnership Executive Group and system partners, but hopefully the work in identifying those priority areas is near conclusion. Following agreement of those areas, we'll carry on working with system partners, but also working with the Leeds Committee of the ICB and its subcommittees to really get behind the ethos of fewer and a much more focused area and provide challenge when it appears that we're trying to do too much and focus on too many things. In terms of identifying a baseline for goal 1, we know that often we set plans and strategies and don't robustly measure our progress towards achieving them. So we're really doing some work in terms of the data to understand what that baseline is and setting that target reduction, which is really important to focus as a system on what we need to achieve. A suitable target in terms of for that goal 1. So we're looking at the difference in health and care activity between the most deprived deciles within Leeds and the rest of the population. We're looking at what other systems have achieved, such as the work of Staten Island. We're drawing on other work that's currently underway and being delivered in Leeds, such as the community mental health transformation and the Home First programme. And then finally, and quite importantly, is the communications plan, particularly aimed at people working across health and sector partnership within Leeds. We want to create a really clear document for them. We also want to create an easy read version, so it's accessible to all people within Leeds. We're also aware that the plan doesn't focus on goal 2, the early intervention identification, which is a significant priority as well. We want to take the learning from goal 1 and the work that we've done to help us inform our approach to understanding goal 2. We also have been working with population and care delivery boards, which have got outcome frameworks for each of their populations. Much of that work focuses on early identification and prevention, so it's really bringing the two together. So I am going to stop there and just thank you for your time. Would welcome any thoughts, feedbacks, and I'm happy to take some questions.
Thank you very much for that. Really interesting your point about point 2, because I'd picked up there wasn't the data for point 2 like you put in for point 1. So thanks for clarifying that. One of the sort of really key things for this sort of system plan is who's paying for what, and it's not a nice conversation to have, but it's something that's sort of the nitty-gritty reality of how that works, especially when it's cross-service. I guess the question is how do we manage that in terms of the system, because I guess there's the council and there's a number of NHS trusts offering different services, and what some services offer or don't offer affects what other services can and can't offer. So welcome your thoughts on that.
Yeah, I think that's it's always a challenging area for a system, and I think what we'd like to say is we focus on the Leeds pound and making sure we make the best use of a Leeds pound. What we have in place is a series of population and care delivery boards that have representation from across the system, include third sector and citizens also. And when we look at making an intervention and a change in line with population outcomes, I think the really important thing is to understand where the impact will be. So as we said in relation to goal 1, we know that unplanned utilisation, not only is it not good for a person, it's not a good experience, it's also not the best use of a Leeds pound, where we could have addressed that challenge upstream. So what we need to do is to do some work on those initiatives to really understand where those kind of changes will be made, what the impact would be, what the costing is, and to look to do what in population health planning we call allocative efficiency rather than technical efficiency. So where can we put the Leeds pound, where can we put the pound that will have the biggest impact in terms of addressing the root cause of what the challenge is. We started to have some of those conversations around those boards. It's not easy, and I'm not going to pretend it is, but there is a commitment to do that, and that's why in this plan particularly we talk about a smaller number of system priorities to really start to test that approach and to take partners on the journey with us. We also talk about kind of small scale pilots, testing, etc., to really build confidence in what the impact of those things could be, because that will be required if we get to the stage where you can obviously shift resources more upstream. The first plan talked a lot about investment upstream, whereas this plan I think is much more realistic in how we try to get those resources to move upstream through really addressing the unplanned utilisation and understanding cost.
Okay, thank you very much. I'll be interested in that work as it develops. Okay, I'm going to bring in Councillor Hartbrook next.
Hi, thanks, Chair. I just wanted to dig into the kind of the priority areas as you've identified, and I'm looking at, well, it's page 19 on your report, but it's page 92 in our agenda pack, and you'll see there's a very small subset of areas within Leeds that are highlighted orange as the areas that are most deprived. And I always get worried when I see things like this, because Leeds is a very, very diverse city, and there are significant pockets of deprivation in most wards. And I worry that in simplifying like this, what I want is assurance that there isn't a postcode lottery, that somebody living in Calverley, Pudsey, Morley North, Ardsley, Robin Hood, Rothwell, or Kippax and Swillington or Garforth isn't disadvantaged in terms of the services and the support they can access compared with somebody in Middleton Park or Beeston Holbeck, or the areas that are coloured in orange. Because to some extent, or to a large extent, if you're deprived, you're deprived, and it shouldn't be a postcode lottery. And I just wanted assurance that that isn't the case.
Yeah, I think when we say IMD1, we can often think to certain wards or areas across the city, don't we? Whereas actually, like you say, there's areas across most of our wards, PCNs, whatever geography you're using, that actually sit in IMD1. I think what we really need to do is to when we identify, well, I suppose firstly what's quite important to say is that there is a lot of evidence that if you do live in our most deprived areas in IMD1, you're way more likely to have an unplanned admission, an unplanned utilisation. So when you actually look at the data, it's actually like a step with IMD1 at the bottom, right up to 10. When you look at planned care, it's the inverse. It's the inverse care law. You're way more likely to have a planned intervention if you live in IMD 10 versus IMD 1. So that's really at the heart of looking at IMD 1. But as you say, there are pockets of IMD 1 across Leeds, pockets of deprivation, and kind of having worked in areas like Morley and Rothwell myself, I've worked on those estates where I know that often they can feel forgotten because people presume that IMD1 is solely in central Leeds. So when we identify our priority areas of focus, we will be looking at IMD1 across Leeds and identifying those areas that we can work with, working through local care partnerships as well to do that. And really taking that approach. I think the other area to not forget as well are the other plus groups as well, which we are groups that we know are disadvantaged from a health perspective, not because of where they live, but because of other risk factors, so gypsies, travellers, etc. So equally, this plan will look to those plus groups also who live throughout Leeds, not necessarily in IMD1.
So if you're covering IMD1 irrespective of where they are, what's served by the map? What happens in those areas that doesn't happen in the others?
In IMD 2 to 10, you mean? Yeah, I mean, I think what's really important to say is that this plan isn't everything, that organisations and sectors have their own improvement programmes that aim to improve services for everyone. And what they do, I guess what this plan's really aimed at is it has a particular focus on reducing health inequalities. And we know that where we work with population and get it right for an area in IMD1, that the learning from that then filters out to the other areas. But that's so I guess this plan is really focusing our resources on the people who we know experience the most health inequalities.
People or areas?
People.
Thank you. Okay, thank you very much, Councillor Hartbrook. Okay, Councillor Ritchie.
Thank you, and thank you both for your presentations as well. I may have got this wrong, I hope I have, but if not, just a plea. You mentioned about creating an easy read version. Can we make sure that they're launched at the same time rather than, it sounds like an afterthought? I may have got that wrong, I hope I have, but if not, please, I'd just ask you that they're launched at the same time, the easy read and the other version.
Yep, so we're planning to launch the strategy in line with the refreshed health and wellbeing strategy. So they go together. With that will be an easy read version. We're working with the Being Well Partnership, the Learning Disability Partnership Group in developing that document as well.
Excellent, that's good to hear. Now, the question I was going to ask, and I will ask now, is this stating island. When I saw that, I thought, wow, that's interesting. And then I looked over on page 71 and saw our projections, which seemed contrary to what was achieved under the Staten Island system. Now, initially, I thought we'd introduce that and I was expecting a drop, but clearly we haven't. But I had to look it up, but it's New York in it. It's New York. I don't get out much. I'm not tagged though, so don't just quash any of those rumours. So I just wondered, are we going to look at that? Is that the idea? Is it feasible? Because as I say, it's a different healthcare system, I think, in the US, isn't it, than over here?
Yes, it's a really different health system, but what we're looking at is the methodology that they used in terms of a data-led approach. So what they were able to do is really drill into their data, and it was a really interesting process in terms of taking a real health-led approach and target and goal, similar to what we've done. But actually, when they've followed that root cause right down, and we've talked about it, I've heard you talking about it earlier around housing, is when you look at the children's paediatric example, when they really looked at those root causes, it wasn't a health-based cause, it was housing. It was working with people to get mattress protectors out to people. It was working to get vacuums into people's apartments. It was working with pest control. They were all the much wider determinants of health. And that's the real focus of this plan, is we want to be able to take that methodology and use it the same. Yes, our data capabilities aren't quite matched to Staten Island, but we're working on those, we're developing them. And we would love to be able to drill right down into this data. We're getting there, and be able to look at it by street, by neighbourhood, by blocks of flats, and be able to really drill down and understand people's health needs, and then follow that root cause all the way along.
So these projections then, is that because it'll take longer for that process to bear fruit, as it were? Is that?
I think the projections you've seen of a kind of, I'm going to say do nothing position. I don't really mean that, because all our partners are doing lots to manage unplanned utilisation, but we're just, the projections that you see are if we take population growth as is and continue to grow at the rate that we're going at the moment, that's what it would look like. What we're looking to do now is to work with the system to understand what our goal is going to be. And you'll have seen in the paper that we're really kind of looking at what a realistic goal for the system, but a stretching goal would be at the same time, and how we set that goal. So the projections there of a kind of population growth and what will happen if population kind of grows at the rate it is, and if our growth in unplanned utilisation remains. What we're looking to now agree and working with system partners and looking at evidence is what we're going to be aiming for as a system. I think in an absolute ideal world, we would have done that before the document. It's the national kind of deadline of getting the document in and not wanting Leeds to have two plans, which is why we are where we are. But we have work ongoing with that. We're quite close, but I think certainly kind of working in the ICB, we want to make sure we've worked with system partners, etc., on agreeing that kind of shared system target, so it's owned. But of course, once we've done that work, we're more than happy to share it with you.
Yeah, thank you, because I think I'd asked for that data to be in there, because I thought it's helpful for us to then know if there is an improvement from the process. So it sort of sets a benchmark, is the way I see it. I'm getting nods, so that's good. Thank you very much. I'm going to bring in Dr. Beale next.
Thank you, Chair. Can I ask for an explanation as to what you're saying on page 114 under the NHS national priorities? And it first of all talks about being able to get an appointment within 2 weeks, or if it's an urgent appointment needed, same day or the next day. And then it goes on, the third bullet point, increase the workforce, brackets, recruit 26,000, next brackets, 515 whole-time equivalent for Leeds, additional roles reimbursement scheme by March 2014. So what is this additional roles reimbursement scheme, and what are these 515 whole-time equivalent for Leeds actually going to be and do? And then ask a more general question, and you might not have the information at your fingertips, but we are constantly told by the ministers that there's been an increase in the number of GPs in this country. But we also hear from the BMA that an increasing number of GPs are working part-time and are not full-time. So I wonder if it's possible to get the information for, say, 5 years ago and for now. How many GPs are there in Leeds? But more importantly, how many whole-time equivalent GPs are there in Leeds? Because if we're going to be able to achieve this national priority, we're going to have the right number of GPs. And I suspect, because in the right-hand column there, it suggests that we're not meeting that requirement, that we're going to need more GPs in order to meet the requirements in the future. So let's ignore what the ministers say. Let's look in terms of whole-time equivalents rather than headcounts, how we've done in the last 5 years and what we need to do further in Leeds to meet the national requirements.
Thank you. So just touching on the third bullet point in that document, and I'm going to apologise that there's acronyms in there, so we'll address that and take those out. So these are the national priority indicators set by NHS England, so at a national level. So in the recently published GP recovery plan, there is a commitment in there that everyone needs to increase their workforce within primary care, and that's on nationally 26,000 roles. So when you break that down for Leeds, it's 515 whole-time equivalents. So that's as a place, we can decide on what those roles are. So within a remit within that scheme, but there's different things that they could be, such as social prescribers, they could be mental health support workers, they could be paramedics within a GP practice, but it is that primary care workforce. So it's based on the needs of each place, what they would like those additional roles to be. In terms of the numbers of GPs we have, I don't have that to hand, but we can absolutely get that for you.
Okay, I'm going to bring in Councillor Farley.
Thank you, Chair. Yes, it was just following on from Dr. Beale's point with regards to GPs. Obviously, we can increase the number of GPs, but if the population increases by a much greater degree, how do we aim to maintain that level of proportionality and to ensure that actually we've got an increase against population expansion? Thank you.
So I guess through the recent reviews, the Fuller review, the stock take review, all of those, and the GP recovery plan it's about how do we use our primary care workforce. It isn't my special area, so forgive me, but we can get it, any information that I miss out. But in terms of those roles, it's about thinking differently, that we know primary care have a real role and should be able to focus on those people with complex needs that need those regular contact with the same GP, so the continuity of care within their primary care service, and we know, and long-term conditions, but also be able to have that prevention focus. We also know that what they're dealing with is that unplanned care utilisation, so that people phoning up and wanting on the day or needing on the day services, and that's actually how is that best offered within Leeds. For some people, they need to see a face-to-face clinician on that day. For other people, it might just be a phone call with a repeat prescription. So it's thinking about different and innovative ways to serve our population based on what their needs are, but recognising there are some people that absolutely need that continuity of carer, whereas others are happy to be more innovative, use online, use text messaging, the NHS app and things like that.
Thank you. I suppose I mean, this might be a bit of a slightly more tricky question, but it's where do you believe kind of the current weaknesses in the system lie? Because ultimately, kind of this is a partnership between all the health providers. It's the ICS, the ICB, the council, third sector partners. And obviously, kind of with while we're talking about kind of what ministers have to say, the line that always comes about is, oh well, the NHS is getting more funding than it ever has before. But again, it's that matter of proportionality, and it's also looking at kind of where the funding has been deducted, because quite a lot of the time the NHS is covering for huge swinging cuts to local authorities, to third sector providers. So how, where are the weaknesses? How do we intend as a system, and this might be for council colleagues also, to address these challenges that are already in place?
I think that one of the areas that we've found challenging is that are those kind of gaps between services, and that's one of the reasons really why we've set up our population and care delivery boards, to bring providers together, setting outcomes, measurable outcomes for what they want to achieve for their population, and recognising that I think kind of following on from that mental health presentation we've had earlier, that these are really complex, challenging problems that actually just looking at mental health from a perspective of mental health just isn't going to solve a problem. So I think I'm not sure I could use the word weakness, but I think one thing we're looking to strengthen is our work between organisations and how people move through the system. And I think if you consider our priorities, one of them is our is home first, and I think that's absolutely that's one example of where we're looking to really streamline how hospitals, social care, etc. Work closer together around the needs of a person. And I think that's where our population approach really kind of stands out, that is around the needs of people and not a setting. And that's really the direction we're working in as a system. I don't know if colleagues have other views.
Okay, do you want to comment, Victoria?
I guess I'll just make a brief comment, I guess, on the question around sort of collective challenge. I mean, I suppose in essence, we know that the demand for services is higher than ever. We know that health needs, lots of indicators have been going in the wrong direction for the past decade, but the pandemic has exacerbated that and given an even greater level of challenge. So health needs in the city are kind of more demanding than ever. And our health services are dealing with backlogs, you know, as a priority. So in order to sort of get ahead and then prioritise more preventative work or more proactive work to, you know, in communities around some of the stuff we've talked about today, is a challenge at the moment. I think we're all finding it's a challenge at the moment just because of the pressure on clearing backlogs. And I think that feels like the reality of where we are. So to make the case for resources sort of more upstream is really challenging at the moment.
Do you want to come back again, Councillor Farley?
Thank you. Yeah, I mean, I suppose again, this is well, at the moment, quite a lot of the discourse around kind of both health and social care is around AI and the idea that technology is just going to swoop in and save us all. Now, I might be a little bit cynical on this because I think actually we've been trying to use different technologies for a protracted period of time, but going forwards. And again, this was one of the real issues with the Health and Social Care Act in 2012. It was the fragmentation of IT systems across the NHS, so that you ended up with clinicians using like Windows XP like 20 years after it was first introduced. How do we as a system aim to remove those discrepancies and differences between kind of the technology that's being used on a day-to-day basis, and what are the technological options on the horizon that you know will bring partners together to sort of smooth out this process?
Go on, I'll have a go at that. It's a really good question. And where do you start with that? There's a lot of different initiatives that are going on in that area. So there's a new Office for Data Analytics, which sits across health and social care. I think that will be a really important development in terms of pulling some of those challenges together. So the population health work that Catherine mentioned will be a key part of that. There's also, and this sits side by side with the Office for Data Analytics, a new digital strategy that is pretty much hot off the press at the moment, actually. And that includes, I guess, the ambition that we've got around digital in the city more generally. It is a bit wider than health and social care, as you might imagine, but more importantly, it also discusses digital exclusion and inclusion, which is a huge issue, particularly in terms of GP access. We know that not everybody can use those digital tools. So there's a number of initiatives that sit under this strategy that a number of partners have funded. So the library lending service is part of that. Some of the initiatives in the community, social prescribing, some of the public health work are very much focused on upskilling people around digital. But you're right. I think the promise of AI is something that I think we can look at. It has been used in some initiatives. So the conversation we had at last Scrutiny around the academic health partnership work, the Pinpoint project, for example, around earlier identification of cancer, uses that type of technology, uses machine learning, but it is pretty much in its infancy at the moment. So there's lots to do, and I think it would be an area probably for scrutiny to absolutely keep an eye on, because again, there are issues, I guess, with data and people's use of data. Obviously, we've got GDPR as a factor as well. So I think there are lots of things that we probably need to keep on the table in how we discuss how we develop our digital approach.
Victoria?
Sorry. Yeah, just to add, and I'm sure everyone in the room is incredibly well cited on this, but we're just incredibly mindful of how fast that agenda is moving, and how any development needs to have people at the heart of how we design services, which sometimes isn't the case when we're in some of the conversations about what tech can do. So I know Health Watch partners and others are keeping a really close eye on this, because we know that most people who use health services are older with multiple conditions, and what might work for a kind of a 20-something professional who just needs a quick consultation about something easily resolvable is mostly not the case for lots of people with more complex issues. And we, you know, one of the major lessons from the pandemic we learned is that we have to design our services around our communities and what they trust and will access. You know, we will kind of fail to learn that lesson at our peril, really. So I know Councillor and I, you know, have got many examples of learning that we'd want to keep embedded at the heart of the conversation, and I think that I'm sure colleagues will, you know, understand that it sometimes when the pressures are on to clear appointments and you have a very kind of system focused conversation about what works best for a system, and I think our challenge is always to ensure that it works best for communities and for people, and I know that's an obvious thing to say, but there are many examples of where that's not happening at the moment. So I think we just need to keep a close eye on that.
Thank you. Do you have one more? Yeah, okay.
Sorry, Chase. Just more of a comment for the rest, for yourself and the rest of the board. I think kind of around kind of the question of technology and AI. I think it'd be really worthwhile sort of like keeping a watching brief of on this subject over the next over the coming months and years. It has yet to be sold to me that Google.com and the private sector is going to save our health system. Perhaps it can't be sold to me, unlike those systems. But I think it's definitely something that we need to keep an eye on over the coming years. Thank you.
Thank you, Councillor Farley. I'll tell you that's a comment. I do think you're right. We do need to keep an eye on the technology and innovation. Okay, Councillor Iqbal next.
Thank you, Chair. Just a quick one. While there's desire to increase the number of GPs to reflect the number of population in the city, but what are we doing about GPs leaving NHS system, GPs leaving and going on locum? There's some dissatisfaction for some reason. I've spoken to a couple of GPs and they says the system's not working, there's something wrong. And they are disappointed because they've done a profession to help and serve people, but there's something wrong. So what are we doing to retain them? How are we going to achieve the target of increasing numbers of GPs?
Just to say, you can answer briefly if you've got a response. We are hoping to have GPs come in September. The GP improving access to general practice is in a September item, but if you want to make a comment now as well, and Angela, definitely make a note of your question, Councillor.
No, it was just to say that I think the best thing would be to get a copy of the GP recovery plan, which is obviously scheduled. So.
Yeah, I'm hoping to have a GP representative here as well from their perspective. Okay, is that okay, Councillor Iqbal? Yeah, good. Okay, Councillor Anderson.
Thank you, Chair. Thank you for the plan. I think it's a really quite an easy read, the plan, apart from in the appendix. There's a lot of detail, but you'd expect a lot of detail because it is a very detailed subject. Something I always struggle with these plans is there's lots of ambitions in here and there's lots of nice words about we will increase the years of life that people lead in good health. How are you going to measure all these things? There's nothing about measurement and what those measures are and how you're going to achieve this. There are some statistics about we will reduce suicides by 10%, which doesn't really sound very ambitious to me. And we're going to shorten the years of life expectancy between the most deprived and the best areas by 10%. Again, for a 5-year plan, if you measure that in the amount of months, then 10% is only 6 months. It doesn't really sound very ambitious. So where are the measures? And I can't see anything in here about signposting people to what I think is quite an easy thing to do and might reduce a lot of A&E admissions, people using pharmacies first. Thank you.
Thank you very much. So in terms of the statistics around the 10% reduction in terms of suicide and the gap in life expectancy are the West Yorkshire 10 big ambitions. So they are set from a West Yorkshire perspective, but happy to share their plan with you if you'd like a copy of that in terms of the detail that sits with that. And then in terms of the measurements that are aligned to the outcomes for the different populations, there is an outcome framework that sits with each population, which has got clear outcome measures and then process measures that sit alongside that. So the process measures are in place to understand that short term, can we monitor progress, because some of these outcomes may take a number of years, and then the outcome measures are more longer term measures. So they're in place for each of the 9 population boards and the 2 care delivery boards. Again, happy to share a copy with you.
Might be somewhere you could maybe allude to where the measurements and where that can be found.
Yes, thank you. We'll add that into the document.
It's one thing when we were working with our population and care delivery boards, we were quite insistent on with outcomes frameworks that each outcome has something that we can measure, not something that we perhaps could measure in different circumstances, but has some data that we can measure it by. So absolutely right. We've got that principle and we can share those measures.
Okay. I can't see anyone else indicating. So I'm going to just sum up again. So thanks for coming. Really interesting discussion. I think, again, we've got at least 4 bits of additional information that we want afterwards. I think something around the full-time equivalents of GPs in Leeds, we're very interested in that, and where we've been over the last 5 years. I think that's really important. Something around the cost of how we do cost sharing. And then the point that Councillor Anderson has made around the process and measures and outcome measures, and then also something around the West Yorkshire ambition. So hopefully that's all okay. Thank you very much for coming. I really think this is helpful, and I'm sure we'll see you again. And also really, really nicely leads us on to the next item. So this is a late item, and I'm hoping that we won't run on it too long because we talked about it in a working group. I just firstly want to apologise to Councillor Arif and Councillor Iqbal because the working group was on Eid. I've got your apologies. That's totally understanding, but I think you understand the timing meant we had to do it quickly. I guess the link for me with this plan is that on page 69 of PAC, our first Leeds health plan priority is to reduce preventable unplanned care utilisation across health settings. And I think we've talked about quite clearly previously how obesity is probably one of those factors that impacts both health inequalities and also preventable unplanned utilisation of healthcare. So hopefully that makes sense. Hopefully you've read it. I think the plan is to send this to the PEG, and I guess the other thing I'd just again like to draw out is that I think there was some information that hasn't come to us around the 5-year investment plan that the PEG has seen. So hopefully you've seen the report, which is basically a summary of the discussions we had. But we need to approve it. So before we approve it, any questions, any comments first, and then we'll move on to approval. I'll take stunned silence as everyone agrees. I can see some nods. That's good. Thank you very much. When we hear back, I'll feed that back to the group, and whether we need to bring it to a full public meeting or not, I think we'll discuss in future work items. So that's super. Thank you very much. I'm going to move on to the final item. So yes, we're just going to talk about work items now. So you can stay and listen if you want or not, but thank you very much for coming. Okay, so I'm going to move on to the last item, which is a work schedule. I think there's one thing I meant to tell you. So where we paid 157 at this for that. So in September, we're planning to move forwards the public health annual report to the September meeting as well. I don't know if that means we'll need to put, considering whether we put dental services as a working group as a catch up, because you've talked about it. I wasn't in the board last year, but I know it's talked about a lot. So we might do that as a working group, because each item does tend to take a significant amount of time, which is good. I much prefer to debate it. But that's what I wanted to update you on. Are there any other questions, comments about the work plan?
Members of the board who were here, probably Dr. Beale will remember him. About 5 years ago, we did a scrutiny inquiry into kidney patient transport. And it might be useful to have an update on whether that has got any better. Where people came that were using the service, gave us real life experience. Do you remember that? Yeah, yeah. So it might be good to have an update on that.
Okay, I'm not aware of. Yeah, that's fine. But what I think it's worth doing is we need to look back, see where we are, and then either we need an update to be written to us, and depending on what that says, depends on whether we need to bring it to the scrutiny board. But I appreciate that.
It will help us to test whether scrutiny is having a reasonable input into these things.
Yeah, absolutely. And proof is in the pudding, as they say. Yeah, good. Thanks, Councillor Anderson. Any other comments? No, super. Okay, thank you everyone for coming. I think we've had a really productive meeting. I think we've covered a lot of ground. So hopefully people enjoyed it and look forward to seeing you after the summer. I hope people get some rest and sunshine. Okay, goodbye.